Hello, everyone. Greetings from Tanzania. Thank you very much for joining the webinar that's been organized by Sickle in Africa. I am Professor Julie Makani. I'm Professor of Medicine and one of the principal investigators of the Clinical Coordinating Center. And I will be co-moderating with my colleague, Dr. Ruben Chianomba. And so what we'll do is briefly go through the slides to give you a bit of background about the webinar series. These are, or maybe I'll start with the Sickle in Africa Consortium. So Sickle in Africa Consortium consists of three main entities. One is the Clinical Coordinating Center, with the leadership of myself, Professor Irene Minja and Dr. Siana Nkia. And then we have the Data Coordinating Center with the leadership of Professor Ambrose Wonkam, Professor Nicola Mulder, and Dr. Vicky Nembaware. And then we then have 6 clinical sites in 7 countries. So for the clinical sites, we have Ghana, led by Professor Fred Salfo, Professor Solomon Ofori Akwa, Tanzania, Professor Emmanuel Balandia, Uganda, Professor Sarah Chiguli, Mali, Professor Aljuma Gindo, Nigeria, Professor Biageli Nodu, and then Zimbabwe and Zambia work as one site with the PI, Dr. Patience Puona from Zimbabwe, and Dr. Gwendolyn Kandawasika from Zimbabwe, with Dr. Catherine Chunda Lioga from as a co-PI. We also have 2 co-chairs, Professor Leon Shilolo and Professor Fumi Olopade, and this is a consortium that's funded by the National Institutes of Health, NHLBI, and I would like to acknowledge the presence of one of our program officers, Dr. Ilana Goldberg, in the audience. Welcome, Dr. Ilana. So the talk today will really be about the registry, which is one of the activities that we have been undertaking for the past 8 years. And these are registries that have been established in the countries, so at country level, and these are publications from Nigeria, Ghana, Tanzania, and Uganda, and the publications from Mali and Zimbabwe and Zambia are in progress. And we will hear from Mr. Wilson, who will be able to share in more detail with regards to the work that we are doing. I'll stop here for now, and I would invite my the co-moderator, Dr. Ruben Chianumba, to briefly talk about the organization of this webinar as part of the series and to introduce our speaker for today. Thank you very much for your attention.
Thank you, Prof. Julie, for the kind introduction. And thank you all for also joining. Good afternoon from Nigeria. Yeah, so I'm trying to see if Wilson is on the call. Yes, he is. I will just quickly introduce Wilson to go ahead and make his presentation. This will be a series of webinar series on data science and other activities in Sickle in Africa. So Wilson, please, you have the floor. You can share your slides and start your presentation. Thank you.
So whilst we're waiting for Wilson to share his slides, just a little bit about Wilson. Wilson joined the SADC group to assist the data management and information group with implementing sustainable data management schemas. He's working on implementing mobile health in the SADC group, and this is a group that is housed at the University of Cape Town in South Africa. The role of Mr. Wilson is to find gaps in research which technology can fill. He is also currently working on implementing a mobile health application that will assist patients with pain management, as well as work on implementing pipelines. And as Ruben has mentioned, this webinar is a series that's jointly organized by SADC, the Data Coordinating Center, and the African Consortium of Human Genetics. And it aims to highlight ongoing research in data science and biomedical research, and to expose attendees to cutting-edge methods and approaches in data science. Welcome, Wilson.
Okay, hope you can hear me.
Yes.
Thank you. All right. So as mentioned, my name is Wilson Mupfururirwa. So I'm a developer at SADC, and SADC is part of the SickleInAfrica Consortium. And what we mostly do, we mostly work on data coordination for the consortium. So I'll shut off my screen for now. Okay. So my talk presentation today will be on leveraging data science to strengthen the SickleInAfrica Registry. And I will just briefly introduce, talk about the registry, and then mostly talk about particularly the SickleInAfrica Registry and all the other aspects that we work on in terms of data coordination in the consortium. So a registry essentially is a patient registry, is an organized system that uses observational study methods to collect uniform data, whether clinical or other data, to evaluate specified outcomes for population defined by a particular disease or condition. And particularly for SickleInAfrica Registry, um, the registry focuses on collecting data for sickle cell disease across Africa. So the SickleInAfrica Registry collects data currently for 7 countries, with the addition of three additional three additional sites roughly for the second phase of the project, and it's based on 27 data collection instruments, and these are collected in REDCap and integrates over 1,500 data elements with 92 core data elements. So these are data variables that are collected holistically across the consortium. And in terms of the registry currently, these are the enrollments for each site. And in total, we are just over 39,000 participants in the registry across the 7 countries. And these are the 7 countries that are part of the consortium, with Zimbabwe and Zambia being one site. And in terms of the numbers that we have currently, these reflect the data that's been shared currently. So we have just over 34,000 patients, and these are first visits. So these are actual participants in the registry, and then we have over 40,000 follow-up visits in the registry. So that's a total of over 78,000 visits in the whole registry as a whole, combining the 2 visit types. And in terms of the scope of the registry, so when we get the data, we consolidate it into one main registry from all the different countries, and the main registry that's consolidated across all the different countries has different variable types, with 15 of those being demographic for complications, and with of treatments, hematology, as well as for phase 2 specifically the addition of liver and renal data points. So these are the data points that are collected across the whole consortium as a whole between all the different sites. And in terms of the flow of data, so what happens at the consortium? So data is collected at each of the sites, Nigeria, Tanzania, and the 7 sites that I mentioned. And this data is collected from hospitals, so the patients, and it's collected through REDCap, so which is a mobile application that allows us to collect data from all the patients, and then that data is hosted at the site database. So there is also internal data checks that occurs in the sense of using red caps in the form of data validations that ensures that only specific variables are entered. If it's a date, and then a date variable must specifically be a date variable. If it's a number, it must be specifically a number. So then that data is hosted at each individual consortium site. And once the data sharing agreements have been signed and agreed upon, then the data is sent to us, the data coordinating center. So we receive multiple data sets from all the different consortium sites. And then once we have the data, we harmonize the data to form the main consortium registry. And once we harmonize the data, we then clean it or integrate it to make sure all the variables are the same. And after that, we clean the data to make sure it's of good quality. And then these cleaning process is iterative in the sense that we have meetings with the sites to fix any of the data challenges from each of the sites. And once we have the clean main consortium registry, and then that's then used or presented on the uh, dashboard platform that we host on the SickleInAfrica website. And then once that's done, then the data is essentially presented at consortium meetings, and as well as used for data reporting in the form of our publications and manuscripts. So once we receive the data, in terms of us, what we do here at the Data Coordinating Center is we first harmonize the data since it comes in many different formats. So we receive currently, as mentioned, 7 sites. So we receive about 7 different data sets. And we have to first harmonize this into one main registry. So one of the challenges that we have currently with is in terms of harmonizing that data. So the data comes in sometimes in different languages, and sometimes obviously in different variables are shared between the sites, and these are quite a lot. Sometimes there you can receive over 200 data variables, and you have to harmonize this together. So one of the challenges that we have is in terms of harmonizing that data, these data sets into one. So for example, you could have so we could have data where the data elements, which referring essentially to the columns of the data, where the data namings are different. For example, in one site they could record gender as gender, and in another site record it as a question like what is your gender. And furthermore, you could have obviously the actual data in that's being recorded be different, where you could have male and female, and in another site you could have it encoded as one or two. So essentially, the first step that we worked on is trying to find a more useful and efficient way in terms of harmonizing the data. So for that, we developed a automated harmonization process or script that actually then harmonizes the data automatically from different sites. And so this is mostly machine learning based in terms of the approach that we use. So we receive obviously the different site codebooks. So these site codebooks are essentially books that have codes in terms of what data specifically is collected at each site, as well as how it's reported. For example, if it's a gender, is it reported in encoding as 1 or 2, or it's recorded as male and female? So we have this from all the different sites, and using these data code books, we're able to create mapping systems that we use in scripts in terms of converting particular data elements or naming conversions from different sites to match across all the different countries. And the matching system then is able to find terms that match. And once the harmonization process where you match the variable names or the column names to each other, after that, then the integration process occurs where, for example, if we want cycle-coded genders 1 and 2, we're able to convert that 1 and 2 to say male and female so that it's consistent across the consortium. And so for this system, we currently use a harmonization script that we host on the SickleInAfrica GitHub page. And this is able to then do the whole harmonization process concurrently, and then furthermore after that it does the integration process. And we also in the process of developing a tool for this in terms of instead of using coding application in terms of having to actually code, you are able to then just use it on a web application of sorts. And this is also available in API endpoints as well as in terminal scripting as well, where you are able to use the system. So for example, it outputs score in terms of how similar particular variables are to each other. And once the mapping is done and is agreed upon and reviewed by someone who's doing the harmonization, they're then able to proceed to the integration process. So some of the variables need reviewing. So this system allows us to just fast track the harmonization process, even though it's not as always accurate. So that's why once the harmonization process is done, it needs reviewing by a reviewer that reviews that the mappings are correct, and then able to proceed to the integration process. And in terms of once we have harmonized the data, we also then look at the quality of the data. So for this, we have data certificates that we produce that actually check the quality of the registry for each site, for each of the data for each site. And then once the data is checked in terms of the quality, it produces a quality certificate that's then shared with the site, and also produces parts of the report of sections of the data from the site that needs improving, such as a lot of challenges that we meet is maybe a lot of missing dates, or maybe missing IDs, which should ideally be always present in the registry. And obviously, all of these, once again, these are all provided on the SickleInAfrica GitHub page that we host. And once the data is clean and is shared, is reviewed properly with the sites and properly cleaned, we then host it on the SickleInAfrica dashboard. This is present on the SickleInAfrica website. So we have a few or a variety of dashboards that we provide. So we have the main registry dashboard, which provides the main registry itself. So these are just reportings of the main registry. And then we also have a summary dashboard that provides or reports on the summary of monthly enrollments from all the different sites, as well as a research dashboard that displays research data or research data that's actually ongoing in the consortium. So this is a preliminary page of the registry, the main registry page. So this is the data, the main registry, then that's then presented on the dashboard in terms of all the summary reporting of the data that's actually collected in the registry. And once we have the main registry provided and presented to sites, to the consortium as well, in terms of and all the errors have been addressed, we then work on the analysis. So for phase one, we collected the consortium collected data from 2017 to 2021. So this was for phase one, and this included 3 sites: Nigeria, Tanzania, and Ghana. And then with the addition for phase 2, there was addition of the other consortium sites, which are Uganda, Mali, and Zimbabwe and Zambia. And these collects data from 2021 up until 2026. And when we look at the process, once we receive the data, we, as mentioned, we first harmonize it. And in terms of analysis, for analyzing the data, we then look at descriptive analysis or descriptive methods of the data, and then work on imputation for missing variables, and then association tests and multivariate analysis form part of the analysis steps. So for phase 1, this is the publication that we published in hematology for the phase 1 registry. And in terms of findings from phase 1, these were some of the conclusions that we came up with from the phase 1 data. So hydroxyurea was found to correlate with age at enrollment, then age at diagnosis. This was at the consortium level. So that's indicating that the most of the participants started using hydroxyurea when they joined the study when they enrolled into the hospital. And for Ghana, they had the lowest median age at diagnosis. So most of the patients were diagnosed at a very early age, and most of this was probably because of the newborn screening study that is ongoing in Ghana. And there were also we also found that males were significantly more likely to use hydroxyurea and have received blood transfusions. So there was and this was at the consortium level across all the 3 countries. So this could indicate that there's a greater burden for males, or actually just point at a disparity between the gender disparity in terms of provision for medication and so forth. And also importantly, there were some long survivor patients. These were outlier or patients were diagnosed late and also started hydroxyurea late and survived as well. So these were patients that survived with sickle cell long enough without any medication or medical intervention. And these patients were particularly outliers, even though there wasn't any significant association to any other variable. We couldn't find possible reasons why how these patients survive for that long. Uh, in that phase 1 article, we just found a lot of patients who would survive long. And also this for phase 2 particularly, there is also a large group of older patients, particularly in the Mali registry, and this is particularly for phase 2. So Mali also is a large group of older patients in the registry. And also when we looked at hydroxyurea use in Nigeria, so it's quite varied because there's a lot more hospitals or sites that they collect data from. So they had a wide varying of hydroxyurea use, which range from 0% in some hospitals to 90%, 91% in some regions. Even though there wasn't an association with HDI here for this provision of hydroxyurea use, so suggesting maybe there's other reasons that could point towards this variety. So for phase 1, we had 13,000, just over 13,000 patients, and as I mentioned, it was from 3 sites: Nigeria, Ghana, and Tanzania. And for the data that we had here was mostly demographic, treatment, and complications data. And then with the additional phase 2, we have now just over 34,000 patients from 7 sites. And we obviously same in terms of with demographic treatment and complications, with the addition of lab result data, which include renal data, liver data, as well as blood data like hemoglobin counts and so forth. as well as follow-up data that's also present for phase 2. So that's over 43,000 follow-up visits. So in terms of we have started with working on the phase 2 analysis, and for particularly now, since we have the addition of hemoglobin data points, we were looking at um, the response of hydroxyurea or transfusion efficacy. So we're looking at comparing the hemoglobin levels and other variable between patients, and particularly these two hydroxyurea use. So we're looking at trying to find out if hydroxyurea use is effective, and this would base this by looking as well as at the hemoglobin levels, if of changes in the hemoglobin levels, as well as the follow-up data that we have on terms of the hemoglobin data as well. And we're also trying to look at transfusion or transfused patients versus non-transfused patients to explore the difference in complications or severity, such as anemia and frequency of other complications like jaundice that we have in the data, as well as also trying to look at demographic data, whether or genotype differences influence treatment, as well as looking at even geographic differences, whether they influence treatment. So this is quite common. So this is just point maybe at more at the governmental issues in terms of the provision of certain medications in certain countries of others. And for maybe either for future research or other more leaning towards more biological analysis, was that this data provides a lot of phenotype data, particularly for phase 2, since we have more lab data as well. So in the future, would be useful to see if these phenotypes are somehow guided by any biomarker data or clinical data that we can look at, and even also useful in terms of clustering the data to see if there is somehow any geographic differences in medication provision, in complications, since the countries we have are quite sparse in terms of geographically where they're situated in Africa as a whole. So that's the analysis approach we are working on currently for phase 2. But that's yes, so that's all from that's it from the registry that we're currently working on. Thank you for your time.
Thank you very much, Wilson. That was a great presentation, and a lot of work we've done actually in analyzing the data, putting them together, and then reminding countries of, sending in their data, making sure the data is clean, and evaluating the kind of work that is done across all sites. And then, of course, the quantity of data that you're working with, as everyone can see, is huge, and it's very interesting. So we have some few questions in the chats, and I know I want to encourage more people to send in their questions in the chat box, or if you want to unmute and ask questions, please raise your hand, and then we can enable that. But before then, we have a few questions in the chat. We have one saying that, are the dashboards shiny dashboards? And what tools are used to harmonize the data? So I don't know if you want to take them all at a time or you want to answer them as we read them out. Wilson.
Yes, so the dashboards, so these are in HTML. So that's just HTML and CSS. So these are web dashboards that are developed in HTML, not particularly shiny, which is, I think it's a R package, I believe.
Okay. All right. So yeah, so were the discrepancies in HU and transfusion in relation to sex unanimous across all sites? Maybe you can talk about that more. If the discrepancies that your experience. You mentioned that men were more disposed to using hydroxyurea. Is the discrepancy among HU and transfusion in relation to sex unanimous across all sites, or is it just particular to one particular site?
So this was unanimous across all the sites, not one particular site. So these were found at all the sites.
Interesting. Interesting.
And
Yeah, and then
also
the comment
missed,
saying, yeah, go ahead.
so I missed the first one. So other question was what tools were used to harmonize the data? So as mentioned, that the most of the application system that for harmonization that we developed is in Python. So it's just it's a Python script that we use to harmonize that data.
Okay. Okay, so we encourage more questions. If you want to unmute and speak or ask or make a comment, please raise your hand. And there's a comment by Aminu saying that the newborn screening program is a game changer and looking forward to how to strengthen the program. Yes, of course. You can see the Ghana site with about 0.25% as average age for diagnosis of sickle cell disease. And this is as a result of the amazing work that has been done over the years, in the newborn screening program to identify those that are having the challenge. So yes, newborn screening is a game changer. And yes, it helps to identify these patients early and enroll them into care. Yep. So thank you so much, Wilson. We need more questions, comments.
Hello, I think I have a question on transmission.
Okay, go ahead, Mustafa. Yeah.
Yes, so if I don't know whether I get the explanation clearly. You will kind of measuring the transfusion versus non-transfusion and their effect on the complications. I don't know how you went about that. Were you just looking at it from a snapshot, or you are looking at those that have quantitatively how many transfusion do they have? I just want to, maybe you can provide more explanation on that. Yeah,
Wilson,
35%.
yeah. Okay.
Okay.
Wilson, did you get the question?
Yes. So are you asking how we'll stratify transfused versus non-transfused patients?
Yes, yes. Do you also look at how many transfusion do they have?
So that will depend on if that data variable is present, if that's collected across the consortium.
Okay, okay,
Yeah.
okay. All right, I think that's fine.
So we still just so we just still working on this. So these are not finalized
Oh,
analysis.
okay. Yeah,
Yes.
because I'm trying to get my head around it. How do you connect that? Because the number of transfusion could be important. So if you
Yes.
stratifying
Yes.
them, I
True.
stratifying them by the number of transfusion, or you stratifying them whether they have transfusion or not.
Yes. So some of those data is provided from some of the sites. So we'll need
Yeah.
to look at if they're present at all the sites
Okay,
to
okay,
work on it. Yeah.
okay.
Okay, thank you so much. We have a comment. Yeah, we have a question. Said, Wilson, can you please highlight how the DCC manages collaborative analysis with data analysts from other sites, approach and the tools used?
Pardon, the DC managers collaborate. Oh, okay. So in terms of collaboration, in terms of the analysis, so the way we do the process in terms of the analysis steps. So we do the analysis along with data managers from each site, and then once we do the analysis, these scripts are also provided on GitHub for all the site members to use them as well. And we also have database meetings with the consortium members monthly, where we present the work that's been ongoing. And so this is also done in collaboration with data managers from each site, who are also able to run the scripts. And also, so each step in terms of the analysis approach is presented at the consortium level. And then this is if there's any questions, or in terms of approach, the specific approach that would be applicable in terms of analyzing the data, these are then taken into account when we do the analysis. So essentially, we start off with the data analysis plan first when we start with the manuscript, with the analysis, and this is presented and shared with the sites for feedback. And once that's approved, we start with the data analysis approach. Once again, every step is presented at consortium meetings, specifically the database meeting, where the other site members are present to give feedback.
Okay, so yeah, so from what I got, yes. And then you still talk about the approach and tools. You started by saying that you get a plan, you share with the countries, and then you make input and send. What tools can you share that you use? Just to further digest that question.
Yes, so for the tools used, we create the application scripts in Python and R, and these are provided on GitHub. And we also then have meetings with the site data managers that also they're able to also download the scripts and run them. And I think recently we also had a database workshop, or a data workshop, where we actually went over the data analysis approach, went over all the scripts, and site members encouraged to join and give feedback, also run the scripts themselves. And there's tools such as, I think, Nextcloud, which we use for data sharing, where sites members upload their data for sharing data. And there's also other tools that we use in terms of running scripts for site members, that they're able to run the scripts that we provide.
Okay, thank you. That's deep enough. So there's another question. Mustafa, I see your hand, but we want to take some from the chat before we come back to you. So how has the use of data science improved data quality and completeness in the Sickle in Africa registry so far? How has the use of data science improved data quality? So before you answer, Wilson, I would like to make a comment here. I want to say that, yes, Sickle in Africa has really, through the data science activities, I mean, apart from the trainings that is provided, I am a beneficiary from some of the activities that has been done in Sickle in Africa. And I can say confidently that part of the training all the training that has been provided has helped us in Nigeria, particularly, to improve our data quality. It has helped us to make sure that our data is complete. Currently, we are trying to migrate our data to the hub at SADC for phase 2 analysis. And we have noticed that some sites have, sent in data that are quite incomplete. Perhaps the patient may or may not provide those information. But as a site, you are supposed to tell us if these informations were not available. You should put it up and say, okay, this information wasn't collected or it's not available. So to help data completeness. So the training activities in Sickle in Africa has helped us particularly to improve that. So go ahead, Wilson, to respond.
Yes, so for data science, so we host a lot of workshops on where we actually present different scripts for data quality checks that we use, and we also train in terms of use of REDCap for the sites, use of R for the site members, and this is improved in terms of the completeness of data. So particularly what's important is even the validation systems that are part of REDCap that actually ensure that the data is it's accurate in terms of, particularly if you were to enter a date, that that variable is actually a date or a number or a string. And this has allowed this has allowed site members to actually include this in their REDCap systems, and this has improved the completeness of the data that's actually shared from phase 1 to phase 2 because of actually the use of systems like REDCap and other scripts that we provide. So I think hosting the data quality workshops and other workshops that we host as part of in the consortium actually help a lot.
Yeah, go ahead.
Okay,
I agree with you. Yes, go ahead.
and then there's a question in is that which the oh, okay, so it's just the answer. Okay, cool. How does the consortium ensure community ownership for informed decision making? I'm not sure if I understand your question correctly. Are you referring to patients?
So I think that the question is geared towards how the outcome of the analysis is, radiates back to the community, and then how they own the information that is generated from this database. Yeah.
Okay.
So to inform decision making within that community, I think that's where he's going. But we still have one more question above. So maybe when you finish responding to this, we'll take that one. Then Mustafa will now ask his question. Yeah.
Okay. Yes. So for consortium, so we first of all we publish the results obviously in publications. And once that's done, we, as part of the consortium, we also work with sickle cell disease patients. This is done under Cynthia, Dr. Cynthia Chankwi, who works with the patient group. So also this work is shown to patients. So there is the patient group meetings. So they also work on publications of their own and other research. And this work is so even a consortium makes things that we host. Patients are also included, and they participate in the consortium. Well, so they're in terms of ownership and this data is, I think the work that we do is gravely informed and detailed back to patients that provide this data.
Yes, I agree with you. I will also say that the success of this database has also helped to some of the decision making that we have made here in Nigeria. Currently, we are having a lot of advocacies and then trying to see how to improve the use of hydroxyurea. From the analysis that was done in phase 1, we found out that the use of hydroxyurea in Nigerian sites is quite low. Even in the report you made, from some sites have like 0% to 91%. And then we wanted to find out from this analysis, how and why has this life-changing intervention used so low in these sites? And then because of this analysis and this outcome that has been gotten, we have been able to, make interventions, have a point to speak to government, have a speaking point, and to say, okay, this is the challenge that we're facing. These are some of the things that can be done. So yes, the communities are receiving, and of course, the ownership, the data is in the country, we own it. And then the outcomes from this is what we have, put into decision making. So yes, it has been very useful in making decisions in country. Yeah, so Mustafa, you can go ahead and then ask your question.
Yeah, thank you. Well, that's I'm really enjoying the whole question and answer session. Yeah, I think also what I'm also doing currently is analyzing the data for sickle cell population in the Gambia. What I also saw is that I'm almost very close to 0% non-hydroxyurea use in the Gambia, which is quite interesting and then very good question of many interventions. So, but my question is this. I just listened to a presentation, but I didn't see any. I know you talked about non-surviving patients. what about long-term survivors? Example, those that have survived beyond 30 years or 40 years. Was there any, what did you kind of factor into the analysis?
Sorry?
Long-term survivors, those that have survived beyond 30 years or 40 years in different populations and that are registered, that are part of the consortium. I don't know whether you factor them into the analysis when you were doing the analysis.
Yes, so the long-term survivors, most of them were above 60. This is for phase 1. So these were patients that we started maybe hydroxyurea use in their 30s, or late 40s. And so most of the patients were above 40 years of age. But for phase 2, when we look at for phase 2, the data is particularly for Mali. They have some patients above 80, a few patients that are actually above 8 years of age.
Wow, that's interesting. They live with sickle cell up to 80 years. Yeah, that's interesting. So the data, if someone wants to access the data that is in the in the SADC, for example, you just want to do some bit of comparison to your current population. What's the data access policy?
I think maybe Prof. Julie, could you comment?
Yes, absolutely. So thank you very much for that question. So the answer to that is that we have a data access working group that is chaired by two and co-chaired by two of the co-PIs. So if there is a need, just email the DCC, and then it comes to the working group, and then this then comes to the data coordinating center. Just to comment is that the data that are being looked after by DCC is managing the data, but the data still belong to the countries, and as has been spoken about before, to the communities of the people with sickle cell, but also the other communities, which are healthcare providers, scientists, and the many people who are involved in generating these data. So the process for accessing the data is not a straightforward one, but there is a process for that. The other comment I wanted to make that is the one about the question about community. The answer was specifically about the patient community, but I just wanted to emphasize that these data of close to 40,000 patients have been generated by a bigger community of as I mentioned before, both healthcare providers, scientists, policymakers, and the patient community themselves. And so in terms of being able to make sure that everybody is engaged and is aware, we have those discussions at different levels. And you've heard from Nigeria on how they use that data. The final comment I wanted to make is that the registry has been generated as a resource, and it's a resource that's being used not just for research, whether it's comparative studies or answering questions about long-term survival, but it's also a platform for conducting clinical research. And Sickle in Africa as a consortium is conducting 2 research studies, one implementation science research on newborn screening led by Professor Obi Nodu, and another one on malaria chemoprophylaxis led by Professor Aljuma Gindo and Dr. Rita Mutagonda. So this is an example of the registry as a resource, and then the consortium uses the registry to enroll patients into research. The final comment is how that the registry is used for health, and this is used to inform health planners at hospital level, but also at country level, for them to know the number of patients, the demographic of these patients, so that this information can inform, using real world data, can inform decision-making when it comes to improving health, because it's easier for people to say, we have 10,000 patients in Nigeria scattered across these countries, and therefore, how do we get them hydroxyurea? How much? Yeah. So it helps with health planning, which ultimately helps with the health of the patients, which is a priority for Sickle in Africa. Thank you very much for those questions.
Thank you very much, Prof.
Oh,
Julie, for
thank you
that
very much. That
clarification.
was
Yeah. So, Wilson, can you just quickly attend to this last one? The Abdul Jabbar from Mali is saying that the data which was included are transmission history within 3 months. So, can you please respond to that?
In Mali data, so which data is included here? We are supposed. So the data that's shown, I think it's a cross-sectional data in the sense of the it's data that's transactions, not 3 months data. So it's at a particular point. So this data is quite old in the data at the time that it was recorded. So these data points were recorded. These patients were enrolled in the studies at different times between 2021 and 2026. So the Easter transfusions were shown from the period of visit where the patient visited the hospital. I'm not sure if that answers your
That's
question.
correct. Yes, it does. Abdul Malik, I see your hand. Do you have
No, I don't have a question specifically, but I think he's commenting on what I commented, right?
Oh, is that Mali?
Is it? So I commented.
Yes.
Yeah, so I commented on that because somebody was asking you a question, and I thought that, oh, probably I should help you with that question. I think that person was saying cross-sectional or something, and then I clarified that information. It's not a question, so
Okay. Perfect.
yes.
Okay, perfect. Thanks.
All right, so I will encourage us to please use the feedback form. Please kindly fill it up so we can get feedback for this webinar to help us improve. Wilson, do you have any? Yes, go ahead.
Yes, so I also wanted to mention with others, we're working as well on, we're also looking at imputation of data. So this is work that's being done mostly by Martha, who's part of our team at SEREC. So these are, we're looking at imputation methods for imputing the data. So a lot of missing data points are found in the registry. And we're looking at possible or effective methods in terms of imputing the registry as a whole. There's also a question in terms of how could we collaborate for more data collection from Abdul. So maybe Prof Makani could comment.
Thank you very much. So one of the things that we did as Sickle in Africa is really make sure that we're embedded with the health systems in the countries that are part of the site. And so beyond this particular study involving these 7 countries, we're also working actively with within countries and within the region as well as within the continent to try and make sure that what we're doing now feeds into a bigger process. And so as part of collaboration, the suggestion is that, or what we encourage is for people in countries to work as a country and then to reach out either through their Ministry of Health to either the WHO Africa CDC or directly to us so that you can be part of the bigger group. We have bigger groups that are at country level, like through the Ministries of Health. And we also have other networks that we are involved. The Data Coordinating Center in South Africa has an ontology group that consists of more than 15 countries from all across the world, not just in Africa. So those are examples of networks, consortia that you can join to collaborate. And so with the DCC and CCC, the aim is really to encourage the use of this resource and to encourage learning and collaboration. So simply to answer your question, Abdul Jabbar, is really just email the DCC and then we can take it from there, but also try and reach out to people working in your country to see what work is being done so that we work at 2 levels. Thank you.
Thank you so much, Prof. Yes, and then you agree with me that this is a very, very successful, very informative webinar. I would like to also invite Prof. Julie to give the closing remark to bring the webinar to a close. Thank you.
Can I ask one question before you close?
Yes, please go ahead.
Go ahead. Yeah.
So I am speaking to you from the Caribbean, Trinidad and Tobago specifically. I'm a client living with sickle cell SC. So the hydroxyurea is what I'm hearing being studied here this morning. It's one of the condition modifiers. My question is, are there other condition modifiers being used in your studies, like for example in dairy, and if yes, are they being studied as well? Thank you.
Thank you very much for your question. So what we've presented today as part of this webinar is the registry. Now, beyond the registry, there are clinical studies, including clinical trials, as well as basic science and implementation science studies. And those are separate from the registry. So we can have a discussion. And I'll ask somebody from DCC to put in the email for people to reach out to DCC and the consortium to get responses. But certainly there is interest in looking at other disease modifiers other than hydroxyurea. And thank you very much for joining from the Caribbean. I think I'm aware that we're at the hour. Thank you very much. We're at the hour, and I just wanted to thank very much the organizers, the Sickle Cell Disease Data Coordinating Center, SADC in South Africa, the African Consortium of Human Genetics, and the SickleInAfrica Consortium. And on behalf of all the people working in this area, we really would like to express our sincere gratitude to our speaker, Mr. Wilson, for his fantastic talk and responding to the questions, and to you, the participants. We look forward to the next webinar. Please stay in touch with and look at our website. And thank you all for attending today's webinar. Stay well and take care. Thank you.